Hi, everyone. My name is Gazelle, and I'm the Vice President of Events for LFC. Before we get started, I'm just going to explain a little bit about how this is going to work. We are going to have 4 speakers today, 4 incredible speakers from CHEO, including Dr. Sasha Carsen, Dr. Jason Berman, Ms. Melissa Nicastro, and Ms. Christina Honeywell, in that order. And each speaker will speak for 15 minutes, followed by a 5-minute question and answer period. So if you guys have any questions, please feel free to type them in the chat. Our co-presidents will monitor the chat and choose a representative amount of questions to pose based on the time that we have available to us. Please note that this event is being recorded right now. So we ask that the participants keep their videos and microphones turned off unless it's question and answer time and you'd rather have them on. That's something that you can choose to do, but know that you will be recorded. Fair warning. And on that note, this event is also celebrating LFC's donation to CHEO, the amount of which I will not announce yet. It's a secret for now, but donations to CHEO do fund life-changing research, medical equipment, and facilities for children in need. So we encourage everyone in the audience to make a small donation to CHEO through the GoFundMe that we will provide in the description so we can reach our goal of an additional $100 raised by the end of this evening. So we will now transition into the speaker series. I see a few more people are joining in. For our first speaker, I am very pleased to welcome Dr. Sasha Carsen, who is an orthopedic surgeon with an interest in pediatric orthopedic sports medicine. Dr. Carsen graduated from McGill University and completed his surgical training in Ottawa, so right here. He then obtained a subspecialty fellowship at Harvard University, and he is also serving as an assistant professor of surgery at U Ottawa and is involved in teaching and also in research. Please join me in welcoming Dr. Carsen to the event.
All right, thanks so much, Gazelle, and thanks so much, everybody, for the invitation and the opportunity to speak. Really, as we are just talking about just before we started here, what a phenomenal initiative you guys have developed here. And I think for everybody who's involved, the hundreds of volunteers who put so much into this, just amazing. Kudos to you for all that you're doing in what is a really challenging time. So I was asked to speak a little bit about what I do at CHEO, and then a little bit about how I got to be there and to be doing what I do. So I thought I would keep this relatively general, but I'd happy to go into further specifics kind of as we go. But first, I thought I'd just describe a little bit about my job. So I'm a pediatric orthopedic surgeon at CHEO, and what that means is that I am a physician and surgeon dedicated to the care of the musculoskeletal system in kids. Now, kids is a fairly broad term, but really that's everywhere from prior to delivery. So sometimes we do some consults, although it's not very often, even before a child comes into the world. But primarily it's for children from babies all the way through until age 18, and occasionally actually for kids, that is to say young adults who still have disorders or musculoskeletal problems, who are a little bit older than that too. And that means problems of the bones, of the joints, of the muscles and the tendons, everywhere from the toes all the way up through the spine. And within orthopedic surgery, there's a number of different subspecialties, and pediatric orthopedics is one of those subspecialties. So those of us in pediatric orthopedics specifically look at children. And that can mean taking care of things like fractures. And in fact, probably somewhere on the order of about 50% of the National Capital Region at some point in their life will encounter the CHEO fracture clinic, because somewhere around 50% of families will have some sort of a fracture within the family at some point within a younger person. But it also means we're taking care of things like congenital limb disorders, developmental hip dysplasia, scoliosis, all manner of pediatric musculoskeletal problems that can occur, both congenital, developmental, traumatic, and beyond. My particular area of subspecialization is I happen to be very involved in arthroscopic surgery, which is minimally invasive surgery, and that tends to be a little bit more focused on what we sometimes refer to as sports medicine procedures. But really what that means is basically minimally invasive procedures or reconstructive procedures around the knee, the hip, the ankle, the shoulder, and the elbow. So sort of the main joints, as well as pediatric orthopedic trauma. So those are kind of my areas of interest. My time is largely spent day to day in seeing patients in clinic to assess their injuries or their musculoskeletal disorders, and also to see them in follow-up, as well as seeing them in the operating room, where we perform all manner of musculoskeletal operations. That could be fixing fractures, but it also can be performing reconstructions and repairs of different types. And other parts of my job that become important is that we are a relatively small group at CHEO, in that there are between about 5 to 6 of us within pediatric orthopedics. And there does need to be somebody available for pediatric orthopedics 24 hours a day for a tertiary care center like CHEO. And so we all share time covering what we call on-call responsibilities, that is to say, covering musculoskeletal trauma. And so that can take up a fair bit of time as well. And then the other part of my job that provides lots of really interesting elements is what I would call the academic mission. And the academic mission involves both teaching. And so, of course, we're directly affiliated with the University of Ottawa and with the medical school there. And we also have a residency training program through the University of Ottawa Division of Orthopedics. And so we're always training residents in orthopedic surgery. So that's a 5-year training program that you start after you finish medical school to become an orthopedic surgeon. We also have pediatric orthopedic fellows. So those are orthopedic surgeons who have already done their 5 years of training, who've decided they want to go into pediatric orthopedics. And that's a separate 1 to 2 years that they spend doing subspecialty training. And of course, we're always training medical students who come through on rotations, as well as occasionally we have undergrads through our various, especially research programs and exposures like that. And the other part of the academic mission that's super important, and you'll hear a little bit more about this from Dr. Berman a little bit later on, is research. And an important part of what we do as an academic institution is to not just treat what's in front of us, but also be thinking a little bit upstream and downstream about what happened to bring a child to see me. Why did that trauma occur? Why did that fracture happen? What could be done to maybe prevent that in the future? Or at the time of injury, what could be done to improve the actual treatment itself? Is what we're doing right now the very best we could do, or are there ways we could change that? It can involve things like developing innovations. It can involve testing different treatment protocols and paradigms. It can involve looking at the efficacy of different surgical interventions. It can also involve looking at different diagnostic protocols. And so I do have a fairly active research program as well, but that it can be a little bit on the broad side at times, perhaps a little bit too broad at times, but generally speaking, I'm interested in questions around pediatric ACL and meniscus injuries, both with regards to outcomes and how we can improve them, as well as, even more importantly, how can we prevent them, and the same sort of idea around hip injuries. And then finally, issues around best practices and treatment outcomes when it comes to pediatric orthopedic trauma, so that's to say fractures. So my average week usually involves about 2 days or so in the operating room, and then usually about 2 to 2.5 days in clinics, and then usually about a half day to 2 days involved in research, and then 1 in 5 calls. So you might notice that actually equals more than a full work week, and that's just kind of how sometimes medicine can work. It's one of the really important things to keep in mind when it comes to a medical career, especially when it's academic, is that the balancing of all those various elements can at times be a real challenge. And so that's an important thing to build into sort of your own skill set, even at the undergraduate level too, is learning how to balance various priorities day to day, week to week, and then in the greater sense. So that's basically what I do right now. I don't think I can think of a thing I would rather be doing. I truly love my job. I think now, that said, we all have parts of our job that are less than fun. So for example, maybe writing notes at the end of the day, things like that, or we all have those kind of administrative tasks that are less than fun. But what brings me the most joy in my work, and what gets me excited to get up and get going every single day, is that I get to fix kids. So kids come in broken and I get to fix them. And that is just so intrinsically rewarding. And there's very little else that I can think of in terms of career or even within the world of medicine, that in all of my different exposures, that I found that gave me that sort of immediate reward, that taking a child who's either been injured, or perhaps has a congenital or developmental problem, and making them more functional or more active, or be able to basically just have a better day-to-day quality of life. So how did I get here? Well, of course, that can be a complicated, long story in and of itself. So I'll try to keep it relatively simple. I will say that I'm originally from central Toronto, and I grew up going to a public high school there. And I was lucky enough to have a really, really wonderful, I would say, high school experience. And when I say that, I don't necessarily mean academically, but rather because I just found that I really enjoyed all forms of extracurricular activity. So I was involved in sports teams. I was involved in music. I really enjoyed all different things. And I think my problem, both in high school as well as beyond, was that I just found too many things interesting in many ways. And that was just kind of always my personality when it came to especially the sciences, was that I just found everything just kind of interesting about the world around us. So when it came to going into undergrad, I actually found myself pulled in three different directions in particular. I definitely was interested in the sciences, but I wasn't sure exactly which one. I was very much interested in music at the time, and I was also very much interested in the outdoors. And so I was torn between going into like a music undergrad versus outdoor recreation at Lakehead University, versus what I ultimately decided on, which was a degree in sciences within kinesiology. So it's funny that my reasoning for not going into music or the outdoors, I thought those are the things that I do for fun, and I don't really want to have to think about those as work. But of course, as things like medicine took over more and more of my life, I don't think I've picked up some of my musical instruments in literally more than a decade. But that's the kid having children also kind of affects your time frames that way too. So I did my undergraduate at the University of Western Ontario, a 4-year honors degree in science and kinesiology, which really did have a very heavy bent towards exercise physiology and biomechanics, because I found myself drawn to specifically the sciences around the musculoskeletal system. I just found the way that we interact physically with the world around us to be really interesting. And I loved the physical principles involved. So that was the physics, the engineering, and how they interact with the biology of the human body. I was not convinced that I was going to head towards medicine, but I explored a few other fields. I thought about going into a pure research area, doing a graduate degree. I thought about going into physiotherapy or occupational therapy. But as I explored a little bit the professionals who are around me during my undergraduate degree, the people who I found most interesting happened to be in medicine. And in particular, what I noticed was that through medicine, you could do a little bit of everything if you wanted to, because there were so many different specialties and subspecialties and opportunities to also be academically involved. Now, I also found myself in my undergraduate degree becoming quite interested in policy around healthcare systems and the why of how we do things. And so that led me to become interested in not just medicine, but also how medicine is implemented. So I did my medical degree at McGill as a joint degree in medicine, and also an MBA directed towards sort of health policy and administration. And that was a really, really interesting experience. And that has helped to color a lot of how I see how medicine is practiced and how some of our institutions run too. That's something else that I could talk about for way too long. Within my medical school experience, I found myself really drawn again to the musculoskeletal portion of the both anatomy as well as physiology, and really enjoyed in particular within orthopedics how you could have a direct physical impact. And really, I have to admit that as much as it's tempting to want to say that it's altruistic, that we're just there to help people, but really the truth of the matter is that the reason I do it is because it feels good to me, because I love that intrinsic reward that I get from fixing people. And that is quite literally what we get to do in orthopedic surgery. And that's the really big draw, is it's very much a procedure based field where we take things that are broken or not functioning correctly. We use very physical principles, engineering and biology as well, and how they interact, and use those to take things that are broken or not functioning optimally to make them better. So that was how I directed myself towards orthopedic surgery. And then orthopedic surgery is a 5-year training program, and I undertook that training here in Ottawa. And I really can't say enough great things about our University of Ottawa residency program. I will throw in the caveat that I'm very heavily biased on that, but it's a great training program. And within orthopedics, I had the same problem I had in high school, undergrad, which is that I found everything interesting. I wasn't really sure what I would be most drawn to. Um, and ultimately, I just found that that the areas that drew me in the most was I loved pediatrics for its patient population and for families. I had been a camp counselor through all of my younger life as well. I've always really enjoyed interacting with young people, partly just because I like the sort of the naive side of life too, where you don't have to worry about a child's secondary intentions or secondary gain issues at all. And that was always a big draw to me. And then I also really enjoyed sports medicine because I could really appreciate how some of the finer and subtler points about how the musculoskeletal system functioned could be really, really important when it comes to not just being able to walk around, but being able to function at a higher level, being able to perform. And so I made the decision to subspecialize further with a pediatric orthopedic fellowship, and then with a second fellowship specifically related to pediatric orthopedic sports medicine. As I went through that fellowship training and also my residency training program, I also took the opportunity to undergo training in research methods as well, and take on some mentors who were really key in kind of pushing me down the road of what I would call surgical clinical investigation too. So that's to say, to not just simply be a proceduralist or technician or physician, but also to really think very critically about what it is I do every day and what it is I see every day, and how we can either better understand what it is we're seeing, better understand what it is we're doing, and improve upon those. So that's basically what's brought me back to CHEO, and I've been in practice at CHEO now for a little over 5.5 years. And as much as things like the pandemic bring in all kinds of novel challenges and levels of stress in certain areas you don't expect, really I can say quite honestly that although it can be a demanding field and certainly very time consuming, it's been truly wonderful. Yeah, so that's kind of the relatively short and sweet. And if that wasn't short, but then boy, you don't want to hear me tell a long story.
Great. Thank you so much for sharing all that. What an interesting journey. And I can tell you're very passionate about what you do. So it's a great thing to share with the aspiring physicians of the future. So everybody, you can start sending your messages into the chat. You can either send them to me privately or publicly, and I will select a few to present. So the first question I have here is, in your opinion, what is the most interesting finding of your research so far?
Okay, that's a great question. A tough one to answer because there's so many different. It's hard to sort of pick a favorite. But at the same time, I think the question that kind of triggered my research interest developed when I was in my residency training, and it had to do with a specific type of hip morphology. That is a shape to the hip that predisposes towards a certain type of injury pattern that we've noticed has really exploded over the last 20 years in young people in particular. And as part of a research study that I started while I was a resident, basically we took a group of about 40 kids of two different age groups, who had not been injured, and we did MRIs of their hips, and we did physical exams, and we looked for specific types of findings, and then followed them over several years and repeated those the imaging, and we found that specific types of physical activity levels actually seemed to be correlated to the development of this hip morphology. So this has actually helped to really shape a lot of the other research I'm involved in now, which is to think about what types of variables that we might be able to influence or control when a child is still young that can ultimately have a long-standing or even lifelong effect on how the body is shaped and how the body might get injured or develop into arthritis later on.
Very interesting. I guess this is kind of a jumping point off of that last question. But hello, Dr. Carson. How has your research changed or adapted during COVID? And are you currently looking for undergrad volunteers to help you with your research?
Great question. So, I mean, unfortunately, the answer to the second part is not really. I think that to be perfectly honest, it's been quite competitive in terms of spaces in the best of times, and during the pandemic, we've had to, as a hospital, as a research institute, an institution, we've had to really try to limit. How many people are coming into the building and getting exposed, and also we've had to reassess how we perform research and what is feasible during these times. So the honest truth is, unfortunately, I don't have anything available research wise right now. We're kind of over full for the next little while. That said, what was the first part of the question again? It was oh, how has the research pivoted during COVID? Well, so one thing is that I had one large research program that involved bringing kids pre-operatively and post-operatively to the biomechanics lab at the University of Ottawa. And that lab has basically been shut to kids since March of last year. So that's been a real shame. And what we've had to do for now has been to change our protocols there and kind of develop new, safer program for future gate lab work, which is hopefully going to start up again in about a month or two. But in the interim, we've basically taken the opportunity to refine a lot of what we've been doing and to begin some of the deeper analysis of the data points we already had. We've also been doing our best to pivot where possible, looking at outcomes of what we have been doing and trying to contribute where possible. And I just finished a multi-center study looking specifically at pediatric orthopedic issues within the pandemic and how surgeons across North America are triaging and accommodating for specific pathologies and then changing their treatment algorithms. Because one of the challenges that you guys, I'm sure, see in the media day to day too is that every region, every province, every institution seems to have slightly different protocols. And that's been true in many ways on the clinical side of medicine too, in that we see differences in how patients are being treated, between CHEO versus the Ottawa Hospital, between CHEO and sick kids, between sick kids and BC Children's in Vancouver, to say nothing of across North America. So we're trying to just better understand how a lot of different hospitals and surgeons have made decisions over the last year, and also how we might be able to collaborate a little bit more towards a better unified approach in the future too.
Great, thank you. And we're just going to take one more question because we are a bit short for time, but this is kind of a two-parter. So what is the most interesting surgeries that you enjoy performing, and what has been the most challenging surgery you have performed?
Oh boy, okay. So there's no good answer to either one. I think probably the most interesting thing probably the area that we're most unique right now in Ottawa is I don't think that there's anywhere else in Canada right now doing as many arthroscopic procedures of the hip for children and for adolescents. And so that's an area that was particularly challenging at the beginning to get started with, but an area that has been really fun and rewarding to get into, because I can see very much how things have changed in the last 5 years, taking surgeries that used to require what we call osteotomies, breaking bones or making big dislocations of joints and large surgeries, and basically transitioning them to minimally invasive surgeries that can be done as day operations. Still accomplishing similar things within the joint and on the bone, but just doing it through a less invasive approach. And so that's the area that I think that has been most personally technically rewarding, is developing that skill set and kind of pushing it a little bit too, at least from sort of the Canadian landscape. And then in terms of the complexity side, I think that that probably it may not count as the most complex operation, but one of the ones that can be equally the most stressful and yet also rewarding is when we have a very specific type of semi-traumatic injury to the proximal femur, to basically to the hip joint, that can occur in children. We call this a slipped capital femoral epiphysis, SCFE, or a SCFE for short. And it can be, when it's very severe and what we call unstable, that is a problem that is really, really challenging and has a very high failure rate and huge deformities and nearly 100% risk of progression to osteoarthritis in the future. And there's a somewhat what I would call risky operation that can be very involved and technically demanding that we've started performing over the last few years that I do in partnership with one of my colleagues. And when the opportunities arise, and we do that probably about twice a year or so, do we have a patient that requires that? And when we do that, it's a full day operation and it involves lots of challenges, but it's also what I would call high stress, high reward, or high risk, high reward.
Amazing. Thank you so much for sharing that with us. I think we will probably move on to our next speaker. So thank you so much for speaking with us, Ghazal.
Absolutely. Thank you.
Yes, thank you so much, Dr. Carsen, for your time. And also thank you to Lysandra and Victoria for taking those questions. I'm so happy to announce that we have actually already met our $100 goal toward CHEO. Thank you to our anonymous donors. Your contribution means so much to us. And it looks like we're actually going to exceed our goal for tonight, which is amazing. So thank you guys so much. Our next speaker is Dr. Jason Berman, a name that you will all most likely recognize because Dr. Berman is the CEO and Scientific Director of the CHEO Research Institute and the Vice President of Research at CHEO. He is internationally recognized for pioneering research using zebrafish to study childhood cancers and very rare inherited diseases. His laboratory is the Atlantic node for the Center of Drug Research and Development. And also, he is a full-time professor in the Department of Pediatrics at U Ottawa. So someday, hopefully, we'll be lucky enough to have a class with Dr. Berman. Please welcome him to the figurative stage.
Well, thanks very much, Ghazal. Can everyone hear me okay? So thank you very much for inviting me. Following Dr. Carsen is always a difficult act. He's an excellent speaker, terrific physician and researcher, and probably no surprise to you after listening to him why he won the Investigator of the Year last year at the CHEO Research Institute as nominated by his peers. And he really is a terrific mentor. So while he says he can't take volunteers now, hopefully if there's an opportunity in the future, you'll be fortunate if you get a chance to work with him. I also, like Dr. Carsen, want to applaud all of you for this tremendous endeavor, this whole group that you formed that I think we were saying before that we hadn't been familiar with until the invitation, and really want to thank you on behalf of CHEO. I know Christina is going to thank you on behalf of the foundation in her comments, but really want to thank you on behalf of CHEO for supporting clinical care and research there. So I'm going to do this a little bit differently than Dr. Carsen did and sort of start more at the beginning and then tell you how I got to where I am. And as you heard from my introduction, I basically, my role currently is really more of an administrative role, which sounds pretty darn boring. And why would anyone want to do that? So, and how did I get to this point? And what do I actually do all day? Because I'm sure Dr. Carsen wonders that too sometimes. So let me tell you, so I'm going to start sort of at the beginning and lead up to where I came from. So, I was always pretty sure growing up that I think I first thought I wanted to be a vet, but then I was pretty interested in medicine and pretty sure that I wanted to go to medical school and become a pediatrician because like Dr. Carsen, I had worked at camps and taught swimming and was a lifeguard and did all sorts of things with kids and really enjoyed working with kids and was told that I was good, I interacted well with kids. And so I'm old enough that I actually only did 2 years of my undergrad before I was accepted into medical school. That was sort of the last year you could do that back in 1852. Well, it wasn't that long ago, but it was a while ago. Whereas now really you do need to do an undergraduate degree. Most people do an honors undergraduate degree like Dr. Carsen mentioned, and many people do a graduate degree before they go to med school, a master's or a PhD. So I only did 2 years and I went to York University in Toronto for my 2 years of undergrad. Then I went to the University of Toronto for medical school. And, you know, I went into medical school thinking I wanted to be a pediatrician, but my really only exposure to pediatrician was sort of general pediatrics. And I thought I was probably going to have an office and see kids and give vaccines and do healthy child care. And then, you know, it was a lecture in my second year of medical school that was given by this senior professor, you know, one of those guys with a beard, the whole thing, about childhood leukemia. And I don't think I'd even realized that, you know, kids get leukemia or cancer. I'd been fortunate growing up. I hadn't really been exposed to that. And I remember after that lecture, it's one of those things that, you know, like I could feel like chills and just sitting there. And I said, no, that's it. That's what I'm going to do. And I kept an open mind as I went through medical school. I was sure I was going to do pediatrics, but kept an open mind through other specialties. And as you go through medical school, in your last couple of years, you do what's called clerkship, where you're actually in the hospital. So I was exposed to different rotations, but in the end, I was pretty sure it was going to be pediatric oncology, certainly pediatrics. And I applied to pediatric residency programs and did my pediatric residency at CHEQ in Toronto. And then going through residency, I decided after being exposed to all the various subspecialties, and in pediatrics, there's all the same specialties that there are in adult medicine. So pediatric cardiologists who are heart specialists, pediatric gastroenterologists who are, you know, bowel and liver specialists, pediatric dermatologists who are skin specialists, and pediatric hematologists, oncologists who are doctors who look after kids with cancer and blood disorders. And, you know, that sounds like a pretty heavy ticket, but it was the rotations that I found most interesting. And so I spent a fair bit of time in my residency doing that. And then I applied to fellowship programs, and I wanted to do something different and leave Toronto and actually leave Canada. And I went and I did my fellowship training in Boston at Harvard Medical School and Boston Children's Hospital. And then as part of that training, and again, I really enjoyed doing the clinical care and looking after children with cancer. And, you know, we don't tend to think about cancer in kids. We think about it in adults, but kids get cancer much less commonly than adults. Very different kinds of cancer. And most children with cancer actually do quite well. Their survival rates are really quite good. But what I noticed while I was doing that work was that not everyone was surviving. And those kids, a lot of the kids that survived did so at a pretty high cost in terms of both short-term and long-term side effects, because most of them received chemotherapy that was pretty intense. And in some cases they got radiation, some cases they had surgery, pretty intensive stuff. And so I saw lots of suffering while they were getting their treatment. And then some kids, when they finished their treatment, they were maybe cured of cancer, but we gave them a whole bunch of other problems. They had heart disease, they had weak bones, they needed hip replacements because their hips were damaged from chemotherapy, they had kidney damage, they were deaf, they were infertile and couldn't have children, all sorts of problems. And so really made me think, you know, we probably can do better. And I also thought that, you know, when you do clinical care, you're helping that individual patient, and that is very rewarding. But when you do research and try to find better treatments, you can maybe help many, many patients, not just the patient in front of you. And so I was really interested in getting involved with research. And so I then did a research program called a postdoc in a lab, and I had never really done much research before in a lab. So one of the messages here is it's never too late to do research, because this was well in my training. I'd already done all my medical school, all my residency, and I went into a lab. And in, you know, many people, I was very interested in translational research, and that's sort of a bit of a buzzword. It's now a bit of an old buzzword, but translational research, which means research that can translate to patients. So research that's not just for the sake of research out of interest, not that there's anything wrong with that, but research really that can then impact patient care. And really being doctors doing that kind of research is really helpful, because you know what the questions are. As I was saying before, you know sort of what kind of questions are going to impact patients, because you're seeing those patients in clinic. And so, and doctors who do research, like Dr. Carsen and me, are called clinician scientists or clinician investigators, because you're both a clinician and you're doing research. And so I went into a lab, and many labs that do translational research use animal models, and the most common animal models are rodents, mice, and rats. But this lab, the lab I went into, was looking at a relatively new model that had gained popularity, which was the zebrafish. And these are these little tropical fish that are about the size of a guppy or a minnow, so like the size of your thumb. And amazingly, they they're actually genetically very similar to humans, which is really kind of humbling that they're a lot the same as us. And what's cool is that, around the time that I was going into the lab, we began to understand more and more that cancer is a genetic disease. Not necessarily that it's inherited, but that there's screwed up genes that lead to cancer, particularly in children. And zebrafish have very similar genes to humans. And so that made us begin to think that, if we could use the zebrafish to understand cancer better in humans, could we find better and safer treatments than what we were currently giving, and get to the clinical problem that I realized, that kids were either dying from some cancers or being cured, but at a high cost. And so I went into this lab and began working with using zebrafish to study childhood cancers, and specifically leukemia, which is the most common cancer in children and was sort of my area of interest. And not only do zebrafish have the same genes, but they have all the sort of same cells and really many of the same organs. And so we really could study these things in the fish. And another huge advantage is that the fish are transparent when they're babies. And fish aren't mammals, so they reproduce externally. And from a single pairing of a male and female fish in one breeding, you can get hundreds of these embryos that are transparent. So you can actually look at what's going on very easily just under the light microscope, and you can label cells and genes, and you can have all these fish and parts of fish that glow in the dark. And so that's really cool. And so we began studying leukemia and modeling leukemia in zebrafish by putting different kinds of human genes into the zebrafish, into the white blood cells, which are the cells that are abnormal when you get leukemia. It's a disease of white blood cells, and starting to understand how these genes were causing cancer. So I did that for a few years, and then I had the opportunity to get my first job, and my first job was in Halifax, Nova Scotia, and I was recruited there into a job where I could do research 80% of the time and still look after children with cancer 20% of the time. And so I moved to Halifax and took on this job and started a lab program and ended up being in Halifax for 14 years. And over that time, built up a whole research program where we were using the zebrafish to study childhood cancer. And we made a number of changes over the time, or added things to our research program. Not only were we putting human cancer genes into fish, but we started transplanting human cancer cells into fish. So I would look after patients with leukemia. I would do a bone marrow test where you take some bone marrow out of their hip bone to look under the microscope to make a diagnosis of leukemia. And then with consent from the families, would take some extra and put that into our fish and start studying treatments new treatments in the fish. And so that was really cool. And we were one of the first labs in the world to do that. And what's really cool about that, because people do that in mice as well, when you do that in mice, you have to use specially immunosuppressed mice so they don't reject the human cells. And it takes weeks and weeks, and sometimes they don't grow. And that can be really hard. But in zebrafish, when we put them in the baby fish, we can put them in without immunosuppressing the fish, because they actually don't have a fully developed immune system till they're about a month of age. And so they don't reject the cells. And then the other thing is that we can do these experiments in about a week or so. So we can see the results very quickly. And so what's cool is we take these human cancer cells, fluorescently label them so they glow in the dark, inject them into the fish. The fish are transparent, so we can see these cells going around in the fish and spreading to the various parts of the fish like they would in a patient. And then we can take those fish, and these are really, really tiny, the embryos, and we can add drugs to the water, and we can use like a robot to add drugs to the water, and we can test many different drugs in many different fish at the same time and find the best treatment that might work for that patient. And that's sort of this idea of personalized medicine, understanding the disease better, finding a better treatment, and finding a targeted treatment that actually can cure their leukemia without causing all sorts of side effects. And we did this not just with leukemia, but we did this with breast cancer. We did this with sarcomas, which are bone and muscle tumors that Dr. Carsen helps look after those patients by doing surgery to remove their tumors. So we started doing all of these types of experiments, which were really, really cool, and finding some new treatment approaches, and then joining into some larger Canadian groups where we were getting tumors from across the country from children with really hard to treat cancers that we wanted to try and find better treatments using the zebrafish, and doing it in a fast enough way that that information could maybe go back and help make some treatment decisions. And around that same time also, we started using the fish because the fish are, again, very similar to people. If you expose them to chemotherapy, they develop many of the same side effects. So they develop heart damage from chemotherapies that cause heart damage, or they become deaf. And I know you're thinking, like, well, how can they become deaf? Fish don't even have ears. But they do have these sensory organs on their body called neural mass that help them swim, up and down, so they're not like, swimming like this. And so those actually are very similar to the hair cells in our ear. They become damaged by chemotherapy. And so we started using the fish to be able to find drugs that could protect the fish, protect their kidneys or their hair cells or their hearts from chemotherapy without protecting the cancer cells at the same time. And that could be given to make chemotherapy treatment safer. And then another thing we did during that time was that we, because the fish is so similar genetically to humans, many people were starting to discover, because this is where we're coming into the era of the human genome, and people were sequencing patients and identifying all sorts of rare genetic diseases. And then wanting to know, we found this gene in this patient, is this the cause of their genetic disease, and how do we treat it? And again, because the fish's genes are very similar to the human's genes, if we make that same abnormality in the fish gene, we can see if they get the same effects in a human. So for example, we studied an eye disease that causes blindness. We could see that happen in the fish. We can model that in the fish, and then again, we can test new treatments. And during this whole time while I had my lab, we had graduate students and postdoctoral fellows and lots of undergrads. I think I've had over 30 undergrads through the lab over the years, and really sort of great experience working in this area. And again, really relevant because it's all about trying to solve patient problems and using the fish to solve patient problems. And again, being a doctor as well as a researcher, I can know the problems from the patients, bring them to the lab, but then also when we find better treatments, I can take those back to my patients. So it can be from bedside to the bench, back to the bedside. Or we like to say tank side because of with the fish. So while I was doing all that, and I mentioned I had students in the lab, I discovered, I really like teaching students about research, and I got a lot of satisfaction by seeing students grow and learn about research. And having, one of my favorite things was to take an undergrad who had never done any research before, or a med student or a resident who'd never done any research before, kind of like me when I was going through training, and they were really intimidated about coming into a lab. And because of our great team that we had there supporting them, turning them on to research. And afterwards I'm saying, wow, I had undergrads who came through and said, wow, I want to go to graduate school now, or I want to do more research. That was really fun, and I really liked doing that. And so I started taking on some roles where I was leading some research programs, and that gave me the opportunity not only to help mentor students, but also to help mentor some junior faculty and other doctors and doctors in training, and worked helping them get excited and learn about research. And then in my last 2 years in Halifax, I was serving as the vice president of research of the hospital there, and then had the opportunity to come in 2019 to CHEO to take on my current role. And I really liked that role because it gave me the opportunity in a leadership role to help mentor lots of people with research, and to get to work with talented people like Dr. Carsen and his colleagues, who are physicians that have great ideas and want to do research. And how do we support them to do that? How do we give them the tools? How do we give them the financial resources, the equipment to support them doing that? How do we build programs to do that? And so, for example, we just developed a strategic plan for research at CHEO. So this is a 4-year plan that lays out a blueprint for all the things we're going to do to try to improve research at CHEO, grow research, train new researchers, come up with new programs and new opportunities, bring in things like technology and AI, which I'm sure you've heard about, and then use all this to try to improve care for our patients. Because we really see research as not being on the side of medicine, but in some ways being underneath medicine, that all the things that we do, the clinical care that we provide, is really informed by research, informed by studies and evidence. And the treatments, and people sometimes forget this, but the treatments of today are really because of the research of yesterday, right? Dr. Carsen knows that this kind of surgery is the right surgery to do and not that surgery because he or his predecessors tested that out and find it was the right way to do it. And now we're trying to find better ways to do things. And sometimes we forget that because usually the research to figure something out and bringing that into the patient usually takes months, or in most cases, many, many years. When we think of new drugs, and in addition to the work I've done in the lab, I've been involved with running a number of clinical trials testing drugs in childhood cancer, and I chair currently an international study in a specific type of leukemia that affects children with Down syndrome. When you take a new drug and do work on that and bring that to a patient, that takes many, many years, on average about 10 years. Only with COVID have we really seen, and this has been one of the sort of advantages of COVID, try to find a silver lining, is people have really been able to connect research and how important it is to finding discoveries that really impact people, right? Because this whole, and you've heard in the news that normally vaccine development takes years, and here it's taken months. It's really been shortened. And so people are seeing that connection between vaccine development and getting the vaccines into the public. And it's not just vaccine development, it's all sorts of other things that are important. And research at CHEO has helped inform this. So we've got projects from CHEO researchers that are looking at contact tracing in homes, how easily is the virus spread between parents and children. We've got studies that are looking at the mental health effects of, what happens to kids that are home and isolated and not going to school. Does that increase their rates of mental illness? And what happens to people that had underlying mental illness? Does it make it worse? We're looking at, and you've probably seen this in the news, testing and measuring the levels of COVID protein in the sewage water to use that to be able to detect the prevalence. Are we going to see more COVID the next week or less COVID, and using that as what we call a biomarker to help predict things? So all of that's very important. And we're seeing in COVID this research, how it's really, impacting patient care and impacting the community in a very real way. And so, now bringing it back to my job now, I still do research. I brought my lab from Halifax to Ottawa, and we still do the zebrafish research because I find that very rewarding. I still do patient care and look after children with cancer and blood disorders. But most of the time, I help support my colleagues like Dr. Carsen. And again, the researchers at CHEO, a lot of them are physicians like Dr. Carsen, but there's also nurse researchers and psychologist researchers and social work researchers and basic science researchers, a whole, nursing researchers, the whole group, and to be able to support them to try to improve the health for all of our patients at CHEO and in the community. So I'll stop there and happy to take any questions.
Great, thank you so much for that. That was very interesting. I'm sure all of us would like to have you as a mentor. If anyone has questions, please put them in the chat. So from Parsa, hi, Dr. Berman. In your opinion, what makes someone a good researcher?
So that's a great question. I would say a couple things. First, you need to be curious. You need to have curiosity and ask questions. And you heard from Dr. Carsen, right? He was very curious about the world around him and different things. And so first you have to have a question, because if you don't have a question, it's hard to come up with a research project. You have to be willing to work hard. You have to be able to get along with other people because nobody does research on their own. You need to work in teams and in collaborations with different groups with different skill sets. You need to be patient because research takes time, and you need to have perseverance because most experiments don't work the first time or sometimes don't work at all, and you have to come up with something else. So really curiosity, teamwork, patience, and perseverance. I think those would be the most important things.
Okay, we have another one. So hi, Dr. Berman, what do you find to be the greatest challenge when doing research?
Wow, so that's a great question. I think probably the greatest challenge is time. You know, research takes time, and you need to, and most research, you know, being a researcher is not a 9-to-5 job. Sometimes you're doing experiments in the evening, and sometimes you're doing experiments on the weekend. And when you're doing experiments, you know, with live animals, whether they're zebrafish or mice or whatever, you sometimes have to work around their schedule. Sometimes our fish don't breed. The fish have a sleep-wake cycle. You have to do things when they're awake and not asleep. So you have to sort of work a bit around your animal schedule as well. And that's the same thing with clinical research. You know, you may want to have 20 patients enrolled in a trial, and they don't come in, and there's a snowstorm, and there's, all this stuff happens. Sort of real life happens. So it's really sort of finding the time to be able to get all those things, to get all your research done. And again, being patient, because to get some, to find results and then ultimately to get them confirmed and published is a long road, but very satisfying.
Okay, and then just to wrap it up, someone was asking about like online research opportunities and how people should go about finding them.
So, we've had to, at the Research Institute, we've had to pivot a lot, and you heard Dr. Carsen mention this, because of COVID. And early in March, last March, we shut down all non-essential research at the Research Institute, which is what happened at all the research institutes across Canada. And then gradually we moved to modify things to make them COVID safe, and everyone had to submit sort of new plans that were COVID safe. So a lot is being done virtually, including seeing patients, consenting patients virtually. Lots of the IT-based or database research obviously can be done remotely. But the basic science research where you're working at the bench, that you need to be in, that you need to be on site. And again, because of COVID restrictions, it means that maybe not the whole team can be there at the same time or be there for as long. That goes back to your question before around one of the most challenging things that impacts your time, because research takes time. But so we are, we have now many studies that are up and running in a virtual format. There are lots of volunteers that join labs and work with researchers, particularly in the summer. It's something that we really enjoy. We really enjoy having student volunteers at CHEO. We can't promise anything right now because we don't know what things are going to be like with COVID, and we haven't been able to have student volunteers really since early in the pandemic from a safety point of view. But hopefully, if not this summer, then into the fall, and certainly by next summer, we'll be able to welcome volunteers back.
Great, thank you so much for agreeing to come talk with us. It was very interesting. I think Gazelle, maybe you should take over now.
Yes. Thank you so much, Victoria, and thank you, Dr. Berman. We can all agree that we heard some very interesting things today about research techniques. If you're a fan of research, if you'd like research to continue at CHEO and to see patient care improve, if you'd like to work with zebrafish yourself in the future, perhaps, please consider donating to CHEO. I have put a link to our GoFundMe in the chat again, and we are so thankful for your overwhelming response. So we've decided to raise our goal to $200. We are on our way to achieving that right now. Shout out to Hannah. Thank you so much for your donation. And I'd like to move to our next speaker, our concluding speaker for the speaker session tonight, Ms. Melissa Nicastro. She has been the manager of ambulatory care at CHEO for the past 3 years, and she's been a clinical manager at Ottawa Hospital prior to that for 10 years. I'll pass the mic to her as we're all very eager to hear her speak.
Hi there, everyone. As you said, I'm Melissa Nicastro. I'm one of the clinical managers here at CHEO. And I've been here for the past 3 years. I'm going to probably use a bit of a slideshow. So I'm going to share my screen just because my talk may not be a little bit drier than everyone else's, because as I talk a bit about part of my journey into healthcare and my work here at CHEO, I'd also like to share some information about the equipment that we use at CHEO in our clinics and the wonderful donations that have helped to be able to provide some of this equipment. And so I think it will be helpful for everyone to see pictures of this equipment as I talk about it. Okay. I'm going to just share the screen. Bear with me. Can everyone hear me okay? And can you see my screen?
Yes, we can see your screen and we can hear you great.
Okay, perfect. Thank you. All right, so I have completed my nursing diploma at Heritage College, my post-RN degree at the University of Ottawa, and I've completed some courses towards a certification at Algonquin College. Although schooling was really important for me, it wasn't where all of my learning happened. I was really fortunate to have worked in a small community hospital for the City of Ottawa, the Ottawa Hospital, and now at CHEO. So ambulatory care is also known as outpatient clinics. When we hear that word, it seems a bit overwhelming to people. Often people think ambulatory care, what does that mean? But it's truly just outpatient clinics. And so I'm one of 3 managers who support approximately 26 clinics at CHEO, and most of them are on the main site at CHEO. We do have a couple that are off-site. Part of my role is to make sure that we have enough supplies, staff, clinic time, and equipment to be able to see and manage the patients and families that we care for. So here is, I'm going to share a slide. Can everyone see my slide with the cardiology, some of the cardiology equipment there?
Yeah, you're good.
Okay, so cardiology is filled with many types of equipment that we require on it, that also require ongoing replacement. Right now, we're in the process of building a new cath lab, and the new cath lab will have a dual purpose. It's going to be used as a cath lab as well as an interventional radiology suite. We have fleets of ECGs equipment and echosonography machines that need to be replaced every 7 to 10 years with much more sophisticated technology that enhances imaging and readings of the hearts of our children and our youth. We also perform fetal sonography, and so of course before the baby is actually born. This ultrasound technology helps us so that we can carefully examine the unborn baby's heart and its functioning. The images that our technologists capture help us provide information on how the baby's heart is formed and whether it's working properly. It allows us to see the blood flow through the fetus's heart, as well as look at abnormalities in the formation of the heart. Okay. And so also in cardiology, right now we're looking to invest in something called a disposable Holter monitoring system. These are devices. On the left, you can see our regular Holter devices that we currently have right now, but we're looking to invest in this disposable Holter monitor. And these devices record the patient's heart electrical activity and rhythm, and that helps the doctors in determining whether or not their heart beats, they've got abnormal heartbeats or arrhythmias that maybe need to be treated with medication or other procedures. This new type of technology is really great because they have the families only need to mail back a little computer chip to CHEO rather than returning the whole machine. Right now, we're often seeing our machines that are getting damaged, the cords are getting damaged, or they're not getting returned at all. And many families have difficulties getting to CHEO to return it, or like I said, it ends up being broken, and they're quite expensive pieces of equipment. So by investing in those little disposable Holter monitors, it's a little sticker that goes on the chest, and it's got a little chip in it, and you can remove the sticker, throw that into the garbage, and just mail that chip back to CHEO so that we can interpret and read those that information on the patient's heart. Okay. And so in our GI clinic, we have recently received a donation of a breath hydrogen and methane machine. This machine allows for us testing lactose and fructose intolerance, as well as small bacterial overgrowth. And with the results of this test, it allows us for our patients to get the required treatment or diet instructions with the help of our dietitians that will be able to help alleviate the symptoms that our patients are suffering from. So it's a really great machine. And the machine we had only monitored breath hydrogen, but now this machine actually monitors methane as well. So it allows us to do that. So the other machine on the right, in 2019, we just received this piece of equipment. It's a FibroScan machine, and this was donated by the foundation as well as the Pediatric Liver Foundation. So you never know, maybe some of your funds went towards that. And so this is really helpful for our patients that with liver disease. They benefit from this special ultrasound machine. This allows them to avoid any more invasive or high-risk interventions such as liver biopsies. And then this is our urology clinic with a couple of our nurses with some of their machines. They look a little bit intimidating, the machines, but they're really quite helpful for our kiddos. We use a number of machines in urology. These are just two of them. And one of them is the urodynamics machine, and one of them is a biofeedback machine. The urodynamics machine looks at the urinary system and how well it stores and releases urine, as well as the bladder, and if the bladder is having involuntary contractions that cause incontinence. And the biofeedback machine that we've also just recently received is a machine that helps to teach children to retrain the pelvic floor muscle. So, and then also, here's a couple of machines that we're using currently in the medical daycare unit. I work with our nephrology team. I don't manage the medical daycare unit, but we do work quite closely with them. The machine on the left is a dialysis machine, and we just received a new fleet of those machines. So we're very, very fortunate. And then on the right-hand side, you can see a nurse applying a 24-hour blood pressure cuff monitor. And that blood pressure cuff goes home with the patient, and it enables us to be able to monitor our patients' blood pressures for 24 hours, even while they sleep, so that we can get that information about patients who have hypertension or high blood pressure. So I love my job in AmCare. It allows me to be able to work with many, many different teams. You know, I get to learn a lot working with those different teams. It's sometimes chaotic, but every day is different and never boring. So it's really great. I can stop sharing my screen, but I just thought it would be helpful to be able to share some of those pictures and with the equipment. So I ended up here at CHEO. My background is nursing, like I said, with some varied courses, varied organizations that I worked at. And I think this job really enables me to be able to help mentor people, help, you know, still feel like I'm helping patients. It seems a different type of nursing. Not all clinical managers are nurses, but in my case, I am. And it allows me also to bring that lens of nursing to when issues come up. Our team is comprised of a couple of different managers that bring varied backgrounds. So I think that's really helpful in being able to work with our teams, provide the best patient care we can. And that's about it.
Great, thank you so much for that. It's very cool to see all the different machines and to know that some of the money that we've raised for CHEO is going straight into that. So that's great to see. Our first question here is, what made you decide to take on a management position?
It's really interesting. When I first went into nursing, I actually never wanted to be a manager. I recall one of my professors talking about, you know, you must be able to write papers and do research and help to drive your profession forward. And I often thought about, well, what's wrong with being at the bedside and being that wonderful nurse taking care of patients? And there's nothing wrong with that. But I also think there's roles, many different roles that help to drive that profession forward and to provide patient care. And when I was working on a floor, I was not happy with some of my peers' performance, and I had brought it to my manager, and not really a lot was done about that. And I felt that I couldn't continue to work with people who weren't elevating the care that they're providing to the patient, or providing the same standard of care that I was providing to my patients. And so I looked at opportunities on how I could help make a difference if my manager wasn't going to be able to make that difference. And so I felt that by being a manager, I would hope to be able to manage those concerns that would be brought forward to me, as well to help elevate patient care and ensure that it's at the standard that you want to be able to provide.
Amazing. Yeah, that's definitely an important aspect in the medical field. Just another question that some of my fellow execs had, but what advice would you have to aspiring nurses who kind of aren't sure about where they want to go, and maybe what made you pick nursing?
So I actually hadn't picked nursing as my first career, and actually hadn't done any sciences in high school, but I did promise my mother that I would take a strong math course in high school. And then I had to go back and actually do a year of pre-nursing, which as a more of an adult learner, I think I loved, because it gave you the opportunity to actually, apply yourself as you start to mold and you start to think of your career a little more seriously. But my mother was a nurse, and every day she went to work, she was fulfilled. She enjoyed the care that she provided. And when she was once asked, how can you continue to love or do you still love your job after this many years? And she said, absolutely, I love my job every single day. And the day that I stop loving my job is the day that I'll retire. And so that's what she did. But there's many paths to nursing, and I think over the years I've been fortunate to try different opportunities. I've worked for the City of Ottawa, actually at OC Transpo, doing a bit of occupational health consulting. It was a placement I ended up at after during my Ottawa U placement, one of my placements there, and I ended up working there for a couple of years. I worked at the bedside on a busy medicine floor. I worked in a small community hospital. And so there's many different paths. I've often looked at positions that were posted for the City of Ottawa for street nurses that would be able to help with homeless homeless people. And so I thought that was very interesting. Just recently, this last year with COVID, I've had an opportunity to work collaboratively with the Youth Service Bureau. We were able to help set up some homeless isolation shelters for children and youth who were homeless, but didn't have a place to be able to isolate if they had signs and symptoms of COVID, or if they actually were COVID positive. So it was a great opportunity to network and to be able to connect with them and see a different lens as well of working with youth and children, and different organizations.
That sounds amazing. And I guess kind of going off, it seems like you have had the opportunity to get involved in a lot of different areas. So what is your current favorite aspect of your work? I guess past or present?
Oh, goodness. I love helping to empower people and helping, one job that often people think is not so exciting is sitting down with your staff and doing a performance appraisal, because sometimes those things can be grueling, and giving feedback to staff that maybe is not fabulous. But I think working with staff over time and helping them to work towards their goals or their future goals, or even we've had many staff members who have shifted careers. And I think helping to see that come to fruition, or to see someone flourish, especially someone who has maybe been in a bad place and not really been performing really well, and to see that you've made a difference and allowed them to also do the same with others.
That's amazing. Thank you so much for speaking to us. I'll pass it back over to Gazelle.
Thank you.
Thank you.
Thank you, Lysandra, and thank you so much, Melissa. I really appreciate that you've joined us here for this event, as well as Dr. Carsen and Dr. Berman. It meant so much that you joined us, and I'm sure many of our viewers learned so many interesting things about careers in healthcare they hadn't already considered. So that has concluded the speaker session for tonight. We will have Ms. Honeywell, a foundation liaison, speak later tonight. But right now, we're going to pass the floor to Yifei and Danny, who are our former co-presidents and current senior advisors. They founded LFC in 2018 and have been a central part of the project ever since. I am extremely proud to be working with them this year.
Okay, so hi everyone. I'm just going to keep this quite brief, but I'm sure all of you know that Learning for Charity is a nonprofit organization where all of our proceeds go towards the CHEO Foundation. So I would just like to quickly share our big check with you all to show everybody how much we've donated to the CHEO Foundation. So I'm going to share that now. Can everyone see? Yeah, okay. So in the past 2 years, we've made $10,000 for the CHEO Foundation, and we would like to present this check to Christina Honeywell from the CHEO Foundation.
Yeah, thank you, Yifei. Definitely, I'm just so proud of all the work that we have done. It's a lot of donation, but it's as a result of 2.5 years of sustained effort and growth. And thinking back to 2.5 years ago, I initially pitched the tutoring idea for LFC because when I did tutoring, I found it extremely rewarding to pass on my knowledge to my tutees and it helping them throughout this process. And thinking back again, we started with a really simple club structure and website, but as Yifei and I became stronger leaders, we were able to keep expanding, scaling up our operations and hosting larger events like this one. And we were giving out free mentorship sessions. And when COVID hit, we were able to make a lot of changes really quickly to adapt it to first time fully online operations the past fall. And now it's really amazing to see what LFC has become today.
Yeah, so like Danny said, I'm also incredibly proud of everything Learning for Charity has become. And this donation would not have been possible without all of the amazing members of the club. So we continually have tutors who apply every year and who want to put the knowledge that they learned in class to good use, as well as supporting the CHEO Foundation, which is amazing. So just a quick fun fact is that a third of the 10K donation that we got actually came from fall 2020 alone, which was last semester, which was a very mind-blowing experience to see. And we hope that LFC continues to thrive in this way in the future. So LFC, again, always welcomes your participation as a tutor or a tutee, and make sure to follow our social media to keep up to date on applications in the future.
And nothing would be possible today with our wonderful professors and student organizations who throughout promoted our wonderful cause throughout our entire undergrad experience. And yeah, thank you all of you for your sustained help. And lastly, if I were to have learned one thing working with LFC, it's the value of drive and resilience. So I know this is a bit cliche, but back when we started from scratch, I was pretty scared. This idea really could have failed. But Yifei and I, we pushed through these doubts and we persevered with LFC after learning from each of our failures. And with that comes the growth mindset of always wanting to improve. And that's how we're able to support CHEO today. And I hope that each of you can carry this mindset wherever you go in life and you'll amount to great things. So to wrap this up, I look forward to Lysandra and Victoria's continued efforts with LFC, and especially after Yifei and I graduate. And with every future generation of co-presidents, I know that everyone will continue to expand our mission going forward.
Thank you so much. Okay, I'm going to stop sharing.
Well, thank you both so much for sharing that. Our final speaker for tonight is Ms. Christina Honeywell. She is the CHEO Foundation Liaison, as well as an assistant professor at U Ottawa and a genetics counselor.
Thank you so much. It is my great pleasure and such a privilege to have the honor of thanking you for such a generous gift. It's really on behalf of the doctors, health professionals, researchers whose work you're making possible through gifts like this, as well as all of the families who rely on us, I thank you, especially in these kinds of challenging times, and to know that it's only 2 years, it's just incredible what you've achieved. Thank you profoundly. I think many people don't realize that there are gaps in care and support and research government funding doesn't cover. So it's really donations like this that go such a long way. You've heard tonight from Melissa, you've seen all those great examples of equipment that we've just purchased or that we're excited to purchase. All of the research described by Dr. Carsen, Dr. Berman, all of those great, exciting initiatives are fueled through donations like this. So I hope that you see when you're contributing in this way that you see yourselves in the successes and the excitement and the inspiration that you've heard through the speakers tonight. I could go on all night. I have tons of examples that I could share. I might just touch on a few, but I know I'm standing between you and the weekend, so I'll keep it fairly short. But I was thinking, reflecting tonight on some of the just the really exciting contributions that donor support is making possible. One piece of equipment we're just about to deploy at the hospital that is very exciting for our neonatal transport team is a brand new incubator, like a neonatal transport incubator, and a pediatric platform that's actually going to allow for our small and mighty transport team covering hundreds, thousands of kilometers to transport kids over 5 kilograms. So up until now, they've only been able to transport neonates in the neonatal transport team. It's now going to be the CHEO transport team, and that's thanks to donor support. It may not also come as a surprise to you that this year, with the pandemic, we've really been turning advocacy efforts to our children and youth mental health. So even at the best of times, our ED at CHEO is one of the busiest for mental health presentations, and we've just seen that presentations go through the roof, and unfortunately even for presentations for self-harm and injury. And so one of a huge difference that donor support has been making in the last year is the 24/7 care. So care, children and youth counselors that are available overnight, not just during the day. That's been an initiative that's thanks to donor support like this, and it's just made a huge difference. So they say I could go on and on, but just know that I really hope you will allow yourself to feel proud, to know that everyone at CHEO and the families who are relying on us are so thankful, especially you donated your time, in your talents in tutoring, but also in generating this level of support. It's just stunning. So I hope you know that you're with this gift you are saving, supporting, improving the lives of kids in our community, and for that we are just so thankful.
Thank you so much for that, Gazelle.
Yes, as Victoria was saying, thank you so much for your very kind words. We really appreciate your support, the support of all of our speakers, and also the support of everyone who is attending this session. I just want to conclude by saying that we have nearly doubled the amount of fundraising that we wanted to do with this event. We've raised $180 from tonight alone, the past hour and a half. So thank you so much for everyone who donated and for your time. I hope you have an excellent evening, a good weekend, and a great rest of your reading week.
I'd just like to say again, thank you so much to Dr. Berman, Dr. Carsen, Melissa, and Christina for all coming to speak with us. We really appreciate you guys taking the time and coming to speak with students.
I second that. All of your speeches have been phenomenal. I know I'm feeling super inspired, so I can only imagine how everybody else feels in the room right now. So thank you again.
So yeah, good night, everybody. Enjoy your weekend. Thanks again to our speakers. Thanks to our execs, our whole team. Yeah, we really appreciate you all coming out tonight.
Thank you.